Now that we've covered pyelonephritis, let's move on to some non-infectious causes that can be damaging to the kidney. The first thing is drug-induced interstitial nephritis, also known as tubulointerstitial nephritis. Just like the name says, the patients have white blood cell infiltration into the spaces of the kidney in between the tubules, meaning the interstitial space. Usually there's pyuria with which type of white blood cell? Eosinophils, because it's a hypersensitivity reaction to drugs. This H&E section shows interstitial infiltrates comprised of neutrophils and eosinophils, which is highly suggestive of tubulointerstitial nephritis. Azotemia will be present as renal function declines. It usually results from a hypersensitivity reaction 1 to 2 weeks after taking drugs that can act as haptens. These drugs include diuretics, penicillins, sulfonamides, and rifampin. NSAIDs can also cause a hypersensitivity reaction even months after taking them. Symptoms include fever, rash, hematuria, and CVA tenderness, and sometimes the disease can even be asymptomatic. It's a critical part of treatment to remove the offending drug. Flash quiz. What finding on urinalysis would suggest pyelonephritis in a febrile patient with flank tenderness? Answer: white blood cell casts. Remember that white blood cells will only form casts if there is an infection in the kidney. Otherwise, an infection in the collecting system could lead to white blood cells in the urine, referred to as pyuria, but they would not be molded into the cast-like shape of the renal tubules. Diffuse cortical necrosis is generalized infarctions of the cortices of both kidneys. It happens in obstetric catastrophes such as abruptio placenta, which is a separation of the placenta from the uterine wall leading to generalized intravascular coagulation. Or it can be caused by septic shock, which also causes disseminated intravascular coagulation. It's also caused by vasospasm. This then leads to many small infarctions in the cortices of the kidneys. Acute tubular necrosis is the most common cause of intrinsic renal failure. The interesting thing about this disease, however, is that it's reversible in some cases, but when it is fatal, death occurs during the maintenance phase, which we'll talk about more in a second. It's usually caused by either ischemic or toxic injury to the kidney. Shock, sepsis, hemorrhage, and CHF are all essentially causes of hypotension. This results in a state of renal hypoperfusion, leading to eventual ischemic injury and acute tubular necrosis. Nephrotoxic injury can result from aminoglycosides, radiocontrast agents, lead, cisplatinum, and crush injury. Both ischemic and nephrotoxic injury lead to the death of the tubule cells, usually the proximal tubule and thick ascending limb cells because they are the most metabolically active. As the tubule cells slough off, they appear in the urine as granular, muddy brown casts. This will tip you off in the exam to acute tubular necrosis. There are 3 phases of acute tubular necrosis. First is the inciting event, and this is followed by the maintenance phase, which usually lasts for 1 to 3 weeks. This phase is oliguric, meaning the patient does not generate much urine. If this is the case, what will the patient be at risk for? They will be at risk for hyperkalemia and metabolic acidosis, since potassium and hydrogen ions cannot be excreted. Death most often occurs during this phase. During the recovery phase, the patient excretes the fluids and substances that have been building up, so this phase is polyuric. BUN and serum creatinine levels fall back to normal. There is also a risk of hypokalemia due to overexcretion of potassium. Usually, if patients can get through the maintenance phase, they recover very well during and after the recovery phase. The next topic, renal papillary necrosis, occurs when a person with an underlying risk factor has an infection or immune stimulus affecting the kidney. This causes the renal papilla, seen here at the tip of the pyramid, to necrose and slough off, causing gross hematuria and proteinuria. Now this area is specifically sensitive to hypoxia. Now why is that? Because it's the farthest away from the arterioles in the cortex that bring oxygenated blood. The underlying risk factors include diabetes, acute pyelonephritis, chronic phenacetin use, and sickle cell anemia or trait. Now let's discuss acute kidney injury, which is also known as acute renal failure. This happens when the kidney is unable to meet the demands placed on it. This means the kidney is not able to adequately filter plasma, and this causes azotemia, which is a rise in BUN and creatinine. When you think about the causes of renal failure, it's best to think about them in terms of what exactly is preventing the kidneys from performing their function. This splits AKI into 3 categories: Prerenal, intrinsic renal, and postrenal. Prerenal, AKI, results from decreased renal perfusion to an otherwise normal kidney, such as during hypotension. The GFR decreases as a result in the kidney's attempt to conserve volume. The term kidney injury here is a little misleading because the kidneys aren't actually injured. They're just failing to filter the plasma adequately because not enough plasma is coming to them. Now this leads to an increase in the BUN to creatinine ratio. Now why is this? Because creatinine continues to be actively secreted while BUN gets reabsorbed with sodium. During intrinsic acute kidney injury, there is actual damage to the kidneys, such as acute tubular necrosis or glomerulonephritis. The necrosis leads to debris obstructing the tubules, causing the kidneys to be unable to excrete waste. The urine will have granular casts, and both BUN and creatinine excretion are impaired. However, BUN is normally reabsorbed in greater quantities than creatinine is secreted, so intrinsic renal damage actually leads to a decrease in the BUN to creatinine ratio, because BUN reabsorption has a larger impairment. Postrenal AKI results from some kind of urine outflow obstruction from an otherwise normal kidney, and it's usually easy to detect because the abnormalities that cause it are anatomical and can be detected on CT or ultrasound. In order to have postrenal azotemia, urine flow has to be obstructed bilaterally. Now let's look at some of the lab values that will help you distinguish the different types of renal failure. If urine osmolarity is higher than 500 milliosmoles per kilogram, then you know that it's prerenal because the kidneys are appropriately concentrating the urine. If urine sodium concentration is greater than 40, then you know that the renal failure is either intrinsic or postrenal because the kidneys are unable to reabsorb sodium and it's being excreted into the urine. The fractional excretion of sodium is the percentage of sodium filtered by the kidney which is excreted into the urine. So an abnormally high fractional excretion of sodium, such as greater than 2%, means what? It means the sodium is being filtered through the glomerulus, but it's not being reabsorbed properly by the tubules. This means there is a problem intrinsic to the kidneys or postrenally. Finally, the serum BUN to creatinine ratio can tell you whether the renal failure is prerenal because the ratio will be greater than 20. If it's less than 15, then it'll be intrinsic renal because the kidneys are failing to reabsorb BUN. Flash quiz. A 45-year-old man is hospitalized for hip surgery. 2 days post-op, he becomes oliguric. His blood work is notable for a serum BUN of 40 with a serum creatinine of 1.3. Which of the following therapies would be most helpful? Antibiotics, IV fluids, or furosemide? The answer is IV fluids. This patient has acute renal failure, which you can tell from his oliguria and elevated BUN and creatinine. The fact that his BUN to creatinine ratio is greater than 20 means that this is prerenal, caused by a decrease in renal blood flow in an otherwise normal kidney. Since the problem is decreased perfusion, the best treatment would be to increase the volume of blood going to the kidneys, and that's best accomplished with IV fluids. Antibiotics are unlikely to help, and furosemide will actually worsen his kidney injury since it will further the volume deficit. There are two forms of renal failure, acute and chronic, both of which lead to an inability to make urine and excrete wastes, but they occur over different time periods. Consequences of renal failure can be remembered with the acronym MAD hunger. First is metabolic acidosis due to the inability to excrete hydrogen ions. Patients with renal failure also have dyslipidemia, but it's not quite understood why triglyceride levels increase in these patients. Potassium levels will also rise due to an inability to excrete potassium. As BUN and creatinine fail to be excreted, patients can develop uremia, which is a syndrome marked by nausea, anorexia, pericarditis, asterixis, encephalopathy, and platelet dysfunction. Due to the inability to excrete filtrate, sodium in water is retained. This leads to CHF, pulmonary edema, and hypertension. Because the kidney is involved with vitamin D hydroxylation, what will this do to the development of children with renal failure? Well, it can stunt growth. The kidney is also responsible for production of erythropoietin, so patients with renal failure can have anemia. Patients can also have renal osteodystrophy, which we'll discuss next. Renal osteodystrophy results from failure of the kidneys to hydroxylate vitamin D. Do you remember at which position? 1-alpha hydroxylase in the kidneys converts 25-hydroxyvitamin D to 125-hydroxyvitamin D. So it's at position 1. Without active vitamin D, patients have hypocalcemia, hyperphosphatemia, and secondary hyperparathyroidism. The hyperparathyroidism leads to subperiosteal bone thinning because parathyroid hormone activates osteoclasts to resorb bone and increase serum calcium concentration. In this patient's wrist, we can see the fraying and thinning of the radial and ulnar metaphyses. The hyperphosphatemia leads to tissue calcification. Do you know why this is? Because it causes calcium to precipitate as calcium phosphate in the tissues. The final topic in renal pathology is renal cysts, where instead of a normal kidney with cortex and medulla, a cystic kidney can be obliterated by fluid-filled cysts. The first cause of renal cysts is autosomal dominant polycystic kidney disease, which causes massively enlarged kidneys that ultimately destroy the kidney parenchyma. Patients are adults that present with flank pain, hematuria, hypertension, urinary frequency, and progressive renal failure. Death is usually caused by hypertension or complications of chronic kidney disease. Now, what causes this hypertension? The hypertension results from increased renin production, and it leads to Barry aneurysms and mitral valve prolapse. 85% of cases result from a mutation in PKD1, which codes for a protein called polycystin 1. This is an integral membrane protein involved in cell-to-cell and cell-to-matrix interactions of renal tubules. Therefore, you can imagine that a mutation in this protein may cause cells to proliferate in a disorganized fashion and form renal cysts rather than renal tubules. 15% of cases are caused by a mutation in PKD2, which codes for a protein called TRPP2. The pathophysiology here is similar because TRPP2 and polycystin 1 are part of the same pathway. For the autosomal recessive form, patients are usually fetuses or newborns. Patients can have renal failure in utero, which can lead to what problem? Correct, Potter sequence. Concerns after birth include hypertension, portal hypertension, and progressive renal failure. It is also associated with hepatic fibrosis. The mutated protein is fibrocystin, and it's involved in tubulogenesis and epithelium architecture, so mutating it can lead to disorganized cyst formation. The last disease we'll look at is medullary cystic disease, which is an inherited disease causing tubulointerstitial fibrosis and progressive renal insufficiency. Patients develop cysts in the medulla of the kidney and lose the ability to concentrate urine. The medullary cysts are usually not visualized, but the kidneys will appear shrunken on ultrasound. In the image here, we can see that the patient's left kidney is significantly shrunken compared to the contralateral kidney. As we previously mentioned, it's tough to identify the medullary cysts, but this is how shrunken kidneys will appear on imaging. Prognosis is usually poor. Flash quiz. What is usually the cause of death associated with autosomal dominant polycystic kidney disease? Death is most commonly due to complications of chronic kidney disease or hypertension. This occurs due to increased renin production. Patients have progressive renal failure, which can lead to complications and death. The hypertension can also lead to death through complications such as Barry aneurysm rupture. Now let's finish the renal pathology section by looking at the difference between simple and complex renal cysts. Simple cysts are usually found in the outer cortex filled with ultrafiltrate. They are very common and account for the majority of all renal masses. They are found incidentally and are typically asymptomatic. Complex cysts can be septated, enhanced with contrast on CT, or have solid compartments. These require follow-up or removal due to the risk of what? Malignancy, such as renal cell carcinoma. A 36-year-old man presents for an annual flu shot. He has been treated for hypertension with an ACE inhibitor since age 30. He denies smoking and alcohol use. Family history is notable for his father requiring dialysis at age 50. An older brother recently underwent unilateral nephrectomy to decompress intra-abdominal organs. On examination, the patient appears barrel-chested and has a sitting blood pressure of 135/90. The likely genetic renal pathology is associated with an increased incidence of which of the following? The answer is A. This likely genetic renal pathology is autosomal dominant polycystic kidney disease. The patient's father requires dialysis at a relatively early age, and the patient's brother had an operation for an enlarged kidney, and the patient himself has hypertension. All of these are consistent with autosomal dominant polycystic kidney disease, which is associated with Barry aneurysms in the circle of Willis. Alright guys, that brings us to the end of renal pathology. Keep working hard, keep your heads up, and I'll see you next time.